Good afternoon, everyone, and welcome to today's edition of Black Health Trust. We are so happy that you chose to spend some time with us, and we are very excited to have you be enlightened by our speaker and enjoy what I think to be a very, very informative discussion. So without further ado, let me turn it over to our founder, Dr. Randall Maxey.
Good afternoon, everyone. I hope everyone is having a great day. And I'm presuming everybody on the call woke up this morning, so we're blessed already. I want to thank my co-moderators, Dr. Barbara Neighbor-Stevens, Dr. Ivan Walks, and Dr. Jocelyn Hines. Thank them for all the time that we put in. We put in about 4 years, Barbara, I think. So good. And we've had a number of great speakers. So this is a special broadcast today because we are fortunate to have the current president of the National Medical Association to join us as our keynote speaker, Dr. Yolanda Lawson. And at her luncheon at the NMA, I must have eaten more gumbo and watched people come in with parasols and dancing. It was really an affair to be remembered. And we love you, Dr. Lawson. We appreciate you taking the time out of your busy schedule to come and inform our audience about issues of maternal morbidity and mortality. So as an introduction, I want to say that she is a fellow of the American College of Obstetrics and Gynecology. I mentioned she's president of the National Medical Association. She's board certified in OBGYN. She is in Dallas, Texas, and she is also an associate attending at Baylor University Medical Center. She's the medical director of Abounding Prosperity, a community-based organization that addresses HIV disparities in Target. I could read for the next 10 minutes and I wouldn't cover all of her accolades, but suffice it to say, we're very proud of you and very happy to be here. We also have at her invitation, Dr. Haywood Brown. And Dr. Neighbor-Stevens, could you briefly read his a brief part of his bio?
Well, Dr. Haywood Brown is not a stranger. He gave an outstanding presentation maybe almost 2 years ago, and I would encourage our audience, if you didn't hear that, look in the archives, and those of you who are new maybe don't know that all of our programs since our inception can be found on our YouTube channel and Facebook. Dr. Brown is someone who loves his work and has spent his career trying to improve the life and well-being of Black mamas. And I don't think he would mind me putting it that way. He is a former president of president of the American College of OBGYN, and is the prime mover behind the position that organization took, highlighting the problems going on with maternal morbidity and mortality and calling for changes in the way medicine is practiced to try to improve outcomes. Most notably, in my opinion, the things that were put in place to ensure that at least what needs to be done in the hospital gets done. And certainly, Dr. Lawson, if you disagree with, or I'm incorrect, or as Rachel Maddow would say, am I stating this correctly? That's not the whole story. Problems for maternal morbidity and mortality begin in the prenatal period, actually in the preconceptual period, and can
And
continue all the way through.
and
But
let
at
me
least some things that were put in place to help the hospital. Uh,
and let me add this to what you're saying. That there's recent information that shows that 82% of these deaths that you're speaking about occur in urban areas. And guess who lives mostly in urban areas? So this talk is very relevant to us, and we hope that our speakers will enlighten us on all the things that make our women at risk. Dr. Lawson, floor is yours.
Absolutely. Thank you, Dr. Maxey. Thank you, Dr. Neighbor Stevens, and thank you for the Black Health Trust for having me today. So one of the things we hope to accomplish today, which is why I invited Dr. Haywood Brown, was we were going to talk about just really prevention in Black women's health. And we can discuss and talk about maternal mortality and morbidity. Morbidity is a discussion that we're having more and more about. And so while we know that these rates of maternal mortality, and there's a disparity between Black women and white women in this country, one of the concerns that we're really emphasizing now is the morbidity. These women leaving hospitals intact and with the health they came with. And so it's an elevated discussion, but I think it's a discussion we should be having. In talking about preventive healthcare as a whole and as it relates to Black women, the first thing I hope that we emphasize today is the importance of treating disease earlier, no matter what it is, whether it's diabetes, whether it's heart disease, whether it's cancer. It is important that we are pursuing preventive healthcare measures so that we can capture disease early and treat and manage earlier. Because we all heard, I don't know, maybe I was in junior high or high school, early detection matters. So we hear these messages, but we have to really bring that home. And then when it comes to women's health care, I tell people my youngest patient is age 3. My oldest patient just turned 100. And so the spectrum around women's health care and what a woman needs during those times, right? Whether it's adolescence, whether it's early adulthood, and then that menopausal and geriatric woman. So there's an evolution of that. I hope today we can get into some of around that recommended screening that's recommended for these women, whether that's around cardiovascular disease, which is something I'm passionate about. So I have 3 pillars for this presidential year, and one is the Black women's health agenda. And one of my emphasis points around that is in cardiovascular disease and Black women. And secondly, let's talk about today. I hope we can really discuss around some of the recommended screenings, what people should be getting when, because sometimes our patients in the community hear sound bites. And so I have 25-year-olds coming in for a mammogram, right? But that's not necessarily a recommended screening regimen for that age group, but depending on risk. And so that's why it's so important to have a doctor you trust who can really guide you through life and what you need and when you need it. And so I'm going to start out, Dr. Maxey, if you don't mind, and let's talk a little bit about some of these recommended screenings, and then we can talk about even screening in the perinatal period, because that's another important thing. So as we push collectively to improve the health of Black women, to improve the health of Black women in pregnancy, we have to just think about what their baseline status is and what they should be getting and when. And so when you talk about maternal mortality and morbidity, we know that there are 3 drivers of that. And that number 1 driver is cardiovascular disease, preeclampsia, chronic hypertension for these women. And the second that we look at is their risk of hemorrhage. And then thirdly would be sepsis. But one of the things I often talk about is that about 52% of the deaths that occur in these moms occurs the day after she gives birth. And so many times people tend to think of, oh, it's something that's happening in the midst of her labor. right? Not necessarily true. And then you think about throughout the trimesters, there are risks, right? It could be ectopic pregnancies, all of these things that can happen. But when we think about and drill that down to 52% of these women are dying the day after they get birth. That's significant. And so we need to be thinking about what are those drivers. And one of those significant drivers is around mental health. And so most of that comes from suicide and for substance use and abuse. And so those are things that we collectively, and so I think about this burden not only from the perspective of me as an OBGYN and my OBGYN colleagues and workforce, but what can others, emergency room doctors, our primary care doctors, our anesthesiologists, our behavioral health providers. I look at this as a multifaceted, multidisciplinary approach when we think about how do we save lives, how do we improve the health of Black women as a whole.
So, Dr. Lawson, I'm sorry, Dr. Maxey, I didn't wait for you, but Dr. Lawson, one of the things that I think we here at Black Health Trust really attempt to do is to give vetted information. What can we do, and what do our audience need to do regarding understanding and hearing the right information? You kind of alluded to it with the sound bites. Could you, for example, tell us 5 things women need to do? Certainly don't be limited to that, but at least 5 things that Black women need to do to take care of themselves.
Thank you, Dr. Neighbor-Stevens. Thank you for that question. And yeah, I alluded to it. I didn't want to go into that's a whole section on misinformation and disinformation. I'm sure any of my colleagues in medicine would agree with me. But I am a proponent of improvement in health literacy for our communities, number one. Right. And so I believe that health literacy, and, I live in the state of Texas. And so there are things here, I think sexual and reproductive health should be taught in schools. And so those limitations, I think, have implications, whether that's on STIs, adolescent pregnancy. I even think there's a role when you talk about the maternal mortality piece, that education piece is needed. But 5 things we could do to improve the health of Black women. So regular blood pressure screenings is number 1. And so there's a campaign that's a coalition of multiple healthcare entities, and it's called Release the Pressure. And so the NMA is a partner with the American Medical Association, the Minority Health Institute, the Association of Black Cardiologists, and the American Heart Association. And what this campaign really did was looking at cardiovascular and especially hypertension in Black women. And so we have videos, or we record how you properly take your blood pressure, how women can access blood pressure cuffs, what is the correct numbers. Much of our community may not understand their blood pressure, their ceiling for the top number should be 130 or less, and the ceiling for the bottom number should be 80 or less, right? So 130 over 80 or less. Of course, that's not optimal, but when we talk about a diagnosis of hypertension or mild hypertension, and so we have to be cognizant and make sure our patients and our communities understand what is a normal blood pressure. I'm asked that often. Secondly, we must work on obesity and physical activity in our communities. And so that is something that, especially when you look at Black women in this country, Black women are some of them have the highest obesity rates. And so that's a very important factor because it has downstream effects. Whether we talk about cardiovascular disease, the risk for diabetes, there are some cancers, right, that are related to obesity. Next, I would say our mental health. We continue to deal with stigma around mental health. When you look at, you heard me mention around the maternal mortality piece and the importance of suicide and substance abuse in triggering those high rates. But when you look at 1 in 7 women will have perinatal depression, that's significant numbers. And so we not only deal with the stigma in our communities, we deal with access, right? What does access look like for us? And lastly, our willingness to get help or to speak up and to share. I just left Atlanta yesterday speaking around maternal and infant health at the 100 Black Men's Leadership Summit. And that's one of the things that we talked about. And we actually created a fact sheet for them of how they can help advocate for women and what should they be doing themselves, even though you may not centrally be the patient, of course, but how can you help these mothers and your sisters and your daughters advance the conversation? And then lastly, I'd be remiss if I didn't mention tobacco. For those people who smoke, we know that tobacco use is a leading cause of not only disease, death, and disability in this country. And so those are my 5: tobacco, physical activity and limiting obesity, knowing your numbers around blood pressure and others, and controlling weight, as I stated, and then the mental health piece.
Well, thank you so much. Appreciate that. Our other co-hosts are on, Dr. Hines and Dr. Walks, and I'd like them to join in our discussion if they would.
So, Dr. Lawson, you mentioned perinatal depression, and if you could just talk for a little bit about what that looks like, because a lot of the things and feelings that you have when you're pregnant, especially towards the end, so I don't want to go out. Of course, I'm tired, right? Of course, I'm irritable. I'm sleepy, right? I haven't got good sleep. We know what the extremes kind of look like, but there's a lot of people in the middle who don't necessarily, or for those who are supporting somebody in that space, what are you really looking for? Because I think outside of those, TV worthy cases, we're not exactly sure what's normal under the circumstances.
Absolutely. And I thank you. And I really appreciate you asking that question because, one of the things I talked about this weekend was around many times women don't want to share with their OB. Right. I'm a Black woman. I'm typically very empathetic and open with my patients, but they won't even want to tell me. Many times I do have the partner or the husband calling me. I had one gentleman outside in his car because he's like, Dr. Lawson, she'll get upset if she knows I'm telling you, but she's crying so much. And so sometimes, it's always been framed around the baby blues. Right. And I can even speak to this outside of pregnancy. It's concerning that so many times women chop it up to it's my hormones. And so we have to be very careful with that messaging because that's pretty widespread now. I even have the men saying it. It's her hormones. Well, when we're talking about mental health, many times, and this is coming from an OBGYN, it's more than just your hormones. And so some of that excessive crying, lethargy, energy, apathy, losing appetite, overeating, sleep deprivation. We know that anxiety can be a very significant problem. So sometimes I'll have new moms, they don't sleep already because a baby needs to eat every 2 to 3 hours. And then they're up at the crib, they're checking every 30 minutes, afraid something's going to happen. That's anxiety, and that's not normal. And so while she may not speak up for herself or recognize these things, those family members, those spouses, those boyfriends, those partners, they should be speaking up. And I'm pretty open with folks that it's okay to call me. But I've literally had that. I've had folks, I had one woman, she did call me. She's locked in her bedroom. And I'm like, well, where's your husband? Because she was thinking about taking her life. He was watching the football game. She didn't want to let him know what was happening, right? But I was able to activate, get help out to the house, and get some interventions done. But that observation piece is so very important. But thank you for that question, because I think it's important that we all think about how we can help, and we all need to look out for the signs.
So, Dr. Lawson, I want to go back to something you said a few minutes ago before we lose that, get too far from that train of thought. You cited the fact that 52% of the mortality occurred within 2 days of delivery. But what about let me do the math, the other 48% that fall outside of that window all the way to the end of the 12 months out? Could you speak to that for just a moment?
So let's make sure I'm clear. 52% of maternal deaths occur the day after a woman gives birth. So that's right after she gives birth through that entire postpartum period. So that's why this discussion about extending postpartum Medicaid is so important. From the World Health Organization's definition of a maternal death, it's any woman who dies at any point during her pregnancy up to 42 days post-birth. And so many of you may remember, I remember when I was a resident physician, many times women's Medicaid may last them 4 to 6 weeks. We were trying to squeeze as much health care into that month after birth, get them on birth control. If they were a gestational diabetic, get repeats. We were trying to do everything we could within a 4 to 6 week period, right? And so that's why this policy decision on expanding that coverage to that year after birth, because again, that is significant. So when you talk about what's happening in the midst of the pregnancy, right? I talked about cardiovascular disease, hemorrhage, and sepsis, right? Those would be things that may happen within the pregnancy. And of course, a leading indicator would be ectopic pregnancies, especially ruptured. And then in the postpartum period, we still have this cardiovascular disease. A lot of times people think that just because they made it through pregnancy and delivery, they don't realize you can still acquire preeclampsia postpartum. Right. Many people don't understand that. So when a woman's having visual changes, extreme swelling, there will be some swelling. I explain to patients normally that first week after birth, that's going to happen. You've typically had a lot of fluids and there's a lot of shifts. But when there's headaches, visual changes, I encourage all women to buy a blood pressure cuff, right? When they're pregnant, they need to continue checking even in the postpartum period. But swelling in the hands and the feet, swelling that doesn't improve. Right upper quadrant abdominal pain. So all of these can be factors and symptoms women can experience even in the postpartum phase.
Can you, for the sake of our audience, before Dr. Walsh comes in, speak about what is preeclampsia and eclampsia? Just what is it?
Yes. So preeclampsia is a condition that pregnant women can acquire, and typically your blood pressure is elevated. Typically they have swelling. And typically, we want to check their urine because they begin to spill protein in their urine. So this is a spectrum disorder. You just heard Dr. Maxey mention eclampsia, but even before you get to preeclampsia, there's another disorder which is just called gestational hypertension. They may not be preeclamptic, they may only have high blood pressure, but not some of the other clinical parameters, whether that be abnormal lab results and other physical manifestations of preeclampsia. So there's gestational hypertension, then you can get preeclampsia, and you can get preeclampsia with severe features. And preeclampsia is dangerous because it not only can affect the mother, but it also can affect that unborn child, right? And so by causing abnormalities with the placenta and other issues for the baby. So sometimes delivery is indicated not only for maternal reasons, but also for fetal reasons. And then the spectrum gets more severe when you go into eclampsia, and that's when the blood pressure is very elevated, but at that point, the woman conceives, right? And at that point, we're worried about oxygenation to the baby, and brain injury to moms. Sometimes women can even stroke. And so eclampsia is the most severe form of that, if that helps, Dr. Maxey.
Thanks very much, it does. Dr. Ivan Walks.
Dr. Lawson, I want to thank you for two things, and then I wanted to ask you a question. The first one is thank you for being with us. It's such an honor to have you on the Black Health Trust. And the second thing I want to do is thank you for being one of those very smart doctors that knows how to talk to people in plain English. For those of us that went to public school, it's really nice when we have people that are very accomplished who are able to, as we used to say, break it down so that folks can understand and take away things that are useful for them. you mentioned, I was very excited to hear you mention talking at the 100 Black Men event and hearing you talk about some of the partnerships, because so often in healthcare, we focus on the health issues and the health concerns. And I wanted you to talk a little bit about some of the other aspects of that. What's it like to be challenged with, I don't have enough food for my family. I don't have the resources I need. I'm too far away for follow up when I go home from the hospital. There are other things other than just the important checking the blood pressure, making sure that the screenings are done, that impact people in really profound ways when they're trying to do something as as wonderful as bringing another life into the world. But what am I bringing them into? What home am I taking them to?
Thank you so much. And I just want to share with you, breaking it down is my superpower. That's I'll break it down to the people. I'm real good at that. And so I love that you asked the question, because I think what you're asking is around the social determinants of health. And what are some of these social factors that contribute to that may have other medical disorders and conditions. And so Friday, yes, I was in Atlanta for the 100 Black Men's Leadership Summit. Thursday, I was at the Clinton Presidential Library. And actually, this was an interesting, I spoke there on specifically maternal health, and it was hosted by philanthropy. So Winthrop Rockefeller, the Clinton folks were there, Walton Foundation, and the Surgeon General of the state actually came, who informed me publicly, and she informed the people publicly, she really didn't understand that this was an issue until about a year or two ago. And she is a women's healthcare provider. And so it spoke to me then, right? It spoke to me then that there is still a place to educate. And I actually did that. I made sure that I educated, but it was an interesting setting. So not only clinical folks, policy people, and philanthropy, and thinking about philanthropy's role. We should do that more. And to speaking to this, that morning I actually testified before the Arkansas Congressional Black Caucus. And some of this was around disparities, including maternal health, but also thinking about some of the social factors. And so after my presentation, they probably held me in that room at least 90 minutes to almost 2 hours asking questions. And one of the things they brought to the table are, how do they connect with clinicians? Because they need the expertise, and specifically the expertise of Black clinicians, because many times our perspective is a bit different, because we tend to be closer to our communities and have perhaps lived in these communities. I know I can speak to that self. And so it's interesting as we think about policies moving forward. And I have a huge interest in that piece, but protective policies. A few years ago, I did a presentation to legislators around how using Medicaid as a tool for health equity and to close the maternal mortality gap. We have to think in those frameworks. And I think that the contributions we add in these conversations is specific just because, like I said, many times we're closer to these communities, and I'm told often they're hard to reach. They're hard to reach. But one of the things the legislators talked about, transportation, what's the role there? And so Dr. Maxey, in the introduction, he mentioned that I'm the medical director at Abounding Prosperity. It's a community-based organization. And there we deal primarily with HIV disparities. It sits in a medical desert, right? And so we're strongly encouraging medication compliance, right? If we want to end the HIV epidemic, people got to take their meds. One of the things that we've instituted and found very helpful is Uber Health. And so Uber Health has been a game changer for us to ensure. And so I'm the principal investigator on the study right now, and it's the injectable PrEP. But the problem is you got to come and get your shot.
Well,
So we instituted Uber Health to help eliminate that transportation barrier. And so we know that there is a need for economic empowerment in our communities. We know this. And so, but with where we are, we have to meet people where they are right now. Exactly right. And so we continue to, and so I'm hoping that we can continue to push forward from the policy side, that the National Medical Association, I'm planning some high level policy work coming up. I can announce, and I don't know if it's okay today, but I will share that if Dr. Max, if we have time at the end, that how we can work collectively to engage our policymakers on things that will improve the health of our communities specifically.
Well, thank you. It's mind-blowing that a person who's in charge of public health for a state had no idea this is the problem. That sounds very suspicious to me, that this has to be on purpose. I know we have some questions from our listening audience. Simon, and by the way, is Dr. Brown on yet?
I don't see it yet.
Okay. Dr.
There
Neighbor?
is a question from the chat on YouTube. And the question is, can you speak to the accuracy of blood pressure cuffs sold in pharmacies? And are there units that are better than others? And not just units, but locations, right? Because they have everything from fingertips, wrists, arms, ankles. You can take your blood pressure all over the place. So
Absolutely. Thank you, Dr. Hines, for pulling that question out, because I do think it's important. And so one of the things that I do, and so with this Release the Pressure campaign, and I'm happy to send information to the Black Health Trust to disseminate it through your channels, we actually list the brands, right, that are usually found to be most accurate. The second thing that I do with my patients personally, I ask them to bring their cuff to my office, right, where I can make sure what I'm getting, right, from a manual pressure is, and their machines are equilibrated and reading accurately. And the other thing that I do is many of the community pharmacies, Walmart's, Kroger's, grocery stores have blood pressure cuffs machines in their pharmacies. I tell people check it there too and make sure, right, that you are checking it even outside, even if they're not coming to me. Most pharmacies are equipped to check it there also. But there are resources around some of these machines and what's equilibrated. And I see Dr. Williams is on here. I don't know if he wants to comment on that at all.
Dr. Williams?
I think you're on mute, Dr. Williams. And then someone put in the chat cuff size. And so typically for me, I actually a lot of times order the machine for my patients, and I make sure that I put on there what cuff size they should use. But then also I encourage them, if they're unsure when they go to the pharmacy to buy it, to also check with their pharmacy and make sure it's appropriately sized. Because if you buy a cuff and it's too small, right, you could get an elevated reading erroneously.
And that's an extremely important point, Dr. Lawson. 2 weeks ago, there was an article in JAMA which emphasized that point, that many of the blood pressure cuffs that are used, for instance, in pharmacies are the wrong size, or the blood pressure cuff that an individual purchases may be too small. Many of our ladies have somewhat copious arms, and the cuff may be too small to accurately measure the blood pressure in them. And so there may be an underestimation of the blood pressure. And as a result, the person may not know that they really have hypertension. I wonder if I could ask a question of Dr. Lawson at this point in
Sure.
regards to the issues of preeclampsia and eclampsia. There was also an article that was published showing that the use of prenatal aspirin in especially in Black women may perhaps avert the problem of eclampsia if used before the 20th week. Do you have any comments about that? And if so, if you think that this is a good idea, should that be extended to all Black women who are pregnant?
Absolutely. Thank you, Dr. Williams, for that question. And so it's been depending on your generation of practicing OBGYN, it is not unusual for us to use aspirin, especially for women who come into pregnancy already with essential hypertension or chronic hypertension. So for those women, pretty much across the board, we are going to encourage aspirin therapy for that particular age group women. The other women we may encourage it for are women who have strong family histories of hypertension, right? And so by nature, physically and physiologically, when you get pregnant, your blood pressure is lower. So in the first trimester of pregnancy, women typically demonstrate a lower blood pressure. It will become towards baseline in the second trimester. And then you're right, we can begin to see, because we know that pregnancy can aggravate blood pressure. That's just what it is. And so that's why we are so aggressive many times around managing and controlling the blood pressure. But
And what
yes,
specifically is that aspirin going to do?
we do advocate for aspirin therapy, but specifically, generally, it's going to be for women who have pre-existing hypertension before they get pregnant. And I think your question is, what does it do? Is that what you said,
Yeah,
Dr.?
what's its mechanism of action?
So we are using aspirin because we're talking to the lay community here, Dr. Maxey. So I'll just say we use it because there are positive benefits from an anti-inflammatory aspect and on the placenta. Many times in pregnancy, when you look at what women, some of the results of hypertension on pregnancy, we can see that they can have low birth weight babies because of sometimes there's microclotting in the placenta and in the vasculature. So we do it for the vascular response to improve that, and so that the placental functioning will be appropriate to allow appropriate growth of the baby.
Thank you. I know Dr. Cutter was on and she had a question, I think.
And I just want to add to that, because this is a confusion point for many women who do use aspirin therapy in pregnancy. Typically, we want to discontinue that at 32 weeks, usually around the 8th month, because it can, the ductus arteriosus of the heart, we can get a premature closure if these women don't discontinue therapy. So I say that because I wouldn't want someone in the public to hear this today, go consume aspirin. And I also highly recommend you talk with your physician or your healthcare provider before instituting anything that you hear on this call. Thank you.
Thank you again so much. Is Dr. Cutter available?
Dr. Cutter is still on mute.
Can we
There we go.
Good afternoon.
Hi.
No, hi. My question was just kind of straightforward. I was listening to you talk about motherhood and those 5 points for, Black women I thought were so helpful. And I began to think about the trend of single parent households for Black women and just what the stressors are where that's concerned and all the health impacts. And I was just wondering if you had a perspective on what those single parent household mothers can do for support, not just, in terms of health support, but also for the mental health support. I think that there's a gap there in some cases. And, some of your insights, I think, would really be helpful for those women.
Absolutely. Thank you for that question, because you're absolutely right. When it comes to Black women, there are so many Black mothers that are doing it on their own. And so some people have the family support. And so I do ask folks to lean in on family. I talk about this often. We are so accustomed. I know I was raised this way. You're so accustomed. Someone asks you how you're doing. You're fine. Do you need anything? No, I'm good. Right. And so I really encourage families, friends, whomever, when there's a woman who's given birth, even a woman who's gone through cancer treatment, do what your heart would desire. Just do without asking. Because many times out of politeness, people will decline help. And so I live by the spirit where I just do. I take food even if you don't ask. I offer to take you to the doctor even if you don't ask. I show up even if you don't ask me to. And so I think that all of us have that responsibility to do that for our friends, sisters, and whomever else. As far as community resources, I think that that can be very local, but there are entities such as Black Mamas Matter Alliance, there's March of Dimes, there are resources, right? There are nurse family partnerships. They have a tremendous amount of resources for not only you as a mom, but things for your baby also. And so I really tend to think that some communities have more than others, but lean into those local communities. When you are at the hospital, there's opportunities to meet with a social worker. We often recognize in these single mothers and call for that type of consultation, if you will, to check in and figure out. It may be just helping them get a car seat, because many times they're also dealing with some economic and financial things. It's expensive having a baby this day and age. Not only just the having, but what comes, it's the after and getting there. And so many times we do offer, and I do try to connect my patients or the community to social workers. They can be very, very useful in helping you figure out what resources are available to you locally. I really love that you asked that question. Thank you.
Thank you.
Dr. Sherrod has her hand up, Dr. Maxey.
Okay, go ahead.
Well, good afternoon, and thank you again, Dr. Lawson. It's so good to see you. We were very excited in the Association of Black Women Physicians when we heard that you were coming to talk to the Black Health Trust. And we actually have a working group on infant and maternal mortality, which is led by Dr. Sylvia Swilley, who is actually she's on this session. But my question was concerning doulas and the information right now in the state of California, you know, that we have Medi-Cal benefit for doulas. And I was wondering if you can talk a little bit about that type of support.
Absolutely. Thank you. And so my entire career actually in obstetrics, I've pretty much used doulas. Many of my patient population, they used to call me the midwife doctor. I had a huge population of women who wanted to achieve unmedicated birth. And that led me to actually open up a physician-owned birth center here in the state of Texas. And so I thought it was an opportunity. It was, for me, there were a couple things that led that. And it was an opportunity, though, for me to ensure safe access and oversight. So typically here in the state of Texas, in many places, most birth centers are owned by midwives. And so what would happen if they ran into a complication, they would call my particular group. We backed up one of the large midwife practices. So if they had a woman that could not achieve out of hospital birth, right? Whether it's Pitocin, forceps, assisted delivery, what have you, they were transferred to us where we would achieve that care. And so I had a very good relationship with midwives and doulas in my immediate community. The doula conversation, I have always referred my patients and recommended or offered doulas. Doulas are with that woman from a support purpose throughout the pregnancy. So, and I say that the word support is what the most important aspect, because I think sometimes communities get confused on what doulas do. Doulas do not offer clinical services. Doulas do not deliver babies. That would be OB-GYNs or midwives, but doulas are an important piece of that support and communication. And so sometimes I could send doulas to the house to kind of evaluate and come back and communicate to me. Even in the postpartum period, if I'm concerned, they typically would go and do checks at that woman's house, let me know if her baby blues were a little more than just baby blues. They support them with nursing and lactation. They're typically in the room with them when they give birth. So they can be very helpful, sometimes even helping them to get some of the laboring done at home. Because, you know, many first-time moms, the first contraction, they're running to the hospital and then they get turned away. You got to go back home. It's not time yet. So doulas can help calm some of that anxiety. And then lastly, They sometimes will help them achieve unmedicated birth, whereby they may not need an epidural, right, for their labor. So doulas can be very useful. There is a lot of policy work, as you are aware. I know that California and other states, the majority of states have not credential, or the payers don't pay for doulas. But with Medicaid stepping up to the plate, Secretary Becerra was at the NMA convention this summer in New Orleans. And so there's exciting work being done around the doula space. And so I'm really excited about that, because typically here in the state of Texas, you would just, as a client, pay them cash. And so they have not typically been able to bill their services under insurance or Medicaid for that fact.
And
Yeah,
Dr.
thank you for that. But one other question too, and I remember seeing this video when we were talking about the discrepancy in infant mortality, between Black and white women. And of course, it should be known that the United States, even though we spend more money on healthcare than anybody else, our infant mortality rate, even for white women, is less than the world. So my question is, though, in this video, they showed that midwives' births did not have that same rate of mortality associated with the birthing process as the general overall process. Are you familiar with that data at all?
So Dr. Sherrod, I am quite careful with that data, because as you think about what I just said, if the midwife was having a complication, she would transfer the care to the OB.
Okay.
Right? And
Uh-huh.
midwives typically should be managing low risk pregnancies, not
I
high
see.
risk pregnancies.
I
So
got you.
I'll tell you, when I opened my birth center, really one night I was on call, and I'm on call and the resident is at the desk crying. And I'm like, well, what is wrong? Because I just come out from somewhere else, and I'm coming to the board. And the resident is crying. And I was like, well, what's wrong? We had just received a baby under the care of a midwife who was 36 weeks. She had developed hypertension, and the baby, by the time they get to us, the baby is dead. And so again, kept that baby too long. There is appropriate care for everyone. We want to make sure that whomever you are, however far along you are, you're getting the appropriate care for your condition. And so when it's a high risk condition, we want those midwives to transition or call early enough so that the proper interventions can be done. And so you have to be careful in that interpretation, because they're dealing more with low risk pregnancies. They don't do C-sections.
Right.
Just sheer nature of us doing surgery, some people could have embolism and bleeding and complications of surgery. And so we're dealing with subsets of providers who are not actually doing the same thing.
Thank you.
That
Thank
makes
you so
Gotcha.
much.
Thank you.
Dr. Neighbor Stevens, while you're looking at the chat to see if we have any other questions or hands raised, I have an unfair question, Dr. Lawson.
Okay.
And I'll give you the option of not addressing, but as president of the National Medical Association, are there any concerns with the state of Texas and their stance that they've taken, especially recently, on a young woman who was about 28 years old, I think, who had a condition where her child was diagnosed with one of the trisomies and not expected to live but a few hours past birth, and they would not allow her to have that child pregnancy terminated. But I'll give you your option of kicking that down the road or commenting on it.
So you're asking me, are there concerns?
Any way you want to answer that question.
Okay, thank you. So you're referring to the young woman. Her baby has a trisomy 18, which is generally, I mean, my whole entire career, I've not seen one survive more than 24 to 36 hours. And that's even for women who took it to full term and tried to deliver. It's a very complex thing. And I think it speaks to so many times it's probably not understood all the ethical dilemmas in this field that we have to deal with, right? So that scenario historically is not while it's sad, not uncommon that we have to deal with those types of scenarios when babies have perhaps could be lethal or not genetic disorders. So the loss of options, yes, there is the loss of options, many options here in Texas. We know that there have been some detrimental things that have happened, even when it comes to ectopic pregnancies and all. Some of the messaging has been confusing to hospital systems, to doctors and others. We as doctors tend to be quite cautious and afraid because we can be fined, we can lose our license, and there can be detrimental things to impact our livelihood in addition. But the limitations on that particular case, it's upsetting, but all I could think about is how devastating that's likely to her as a woman. She wanted her baby, right? She wanted her baby. They want a family, right? And an unfortunate situation happened to her. And it's even more unfortunate that she had to, go to another state and and just think about the whole world is listening in to what happened. So I think empathetically about her, and I'm very sympathetic to her situation, because going through that and having a baby with a genetic disorder such as a trisomy it's difficult. It's not wanted. And so it's not an elective termination, but the loss of options is the issue here. And so reproductive health care is important. And I think this is another example how we cannot simplify the messaging and simplify these concepts that are so complex around care.
Thank you, Dr. Lawson. We're
Well,
getting
well,
close to the top of the hour.
Dr. Maxey, if I can just step in. Dr. Lawson, that was such an eloquent and, in my mind, accurate response. I remember years ago, my sister having a baby that only lived a day or two, neural tube issues and all of that. And I think that your focus on the fact that women want to give birth, want to have a family. My sister was married, she and her husband were so excited. And when you're forced to go through something like that, it can be so devastating for the individual, and particularly for their ongoing mental health, their ongoing relationships. And so your response dealing with a loss of options and this simplifying of a very complex individual dependent occurrence is really, I think, an eloquent answer. And what it leads to for me is just how important it is for us to be involved with policymakers and help to educate folks as they are sitting wherever they're sitting, making things just completely off and on when life isn't off and on and our patients aren't off and on. So thank you for that.
Thank you.
Dr. Lawson, there is a question from Dr. Cutter in chat, and Dr. Cutter and I were on the same track. In these last few minutes, would you please help us understand some confusing messaging that is coming out in the preventive world? In two areas, what should we be doing as women who are living longer and don't know whether they still need to have cervical cancer checks or not? And irregardless of the age, the messaging has been totally confusing regarding breast screening and what considerations should Black women take into their personal decision-making when they have dense, pendulous breasts, but they may be 25 years old.
Yes.
And
Okay.
Can I add one more thing to that?
Yes.
Postmenopausal hormone taking.
Okay. We'll go. We can do it. Yeah. We can do this. We got a minute.
I told you there would be no shortage of things to talk about.
No, I love that you bring up the cervical cancer screening because that is so important. If we did nothing else today, I felt like we should address that because, again, messaging and sound bites, it gets confusing. So a lot of women come in now because they're like, well, my primary care said I don't need a pap smear, but every 3 years, right? And so there are women that is appropriate for. And so with co-testing or testing for a human papilloma virus, which we short call HPV, right? So some of it depends on your HPV status. If you are HPV high risk positive, if you're a woman perhaps that has lupus and you take chronic steroids, right? You're considered immunosuppressed. I take care of a large cohort. I do clearances for women who want to have transplants. So I take care of a large cohort of women who are transplanted. It's not appropriate for them to have a pap smear every 3 years. So it's in the small print. And this is when I ask people read the small print. And so while, yes, you can go to every 3 years if your HPV is negative, right? You should still annually, though, get a pelvic exam. So the confusion is, why am I going for an annual, but I don't need a pap smear for every 3 years? The annual wellness exam is more than just the pap smear. That is when we examine your breast. You get a pelvic exam, your uterus, your ovaries, the gross examination of your cervix, right? We do many of those other necessary health screenings during that point, right? And so, yes, leading in, and then that brings up the importance of vaccination and the HPV vaccines and having that discussion, especially now that it's not cut off at age 26, right? And you can get them until you're 45. Secondly, on the breast exam, yes, I do have 25 and 30-year-olds who come in wanting to have a mammogram. And many times an insurance is not going to pay for that unless there's something else medically that warrants it. I found an actual lump. So while the United States Preventive Services Task Force may not recommend the breast exam, we still do think it is proper for a woman to know her breast. It is important to feel, palpate, and know yourself. So when there is something different, because many times women self-diagnose or find a lump themselves and then call the doctor so we can order the necessary imaging. But I still think it's important for us to know the body, examine yourself, and ensure that the screening that's done, because for a 30-year-old who has a lump, yes, it may not be a screening mammogram that I'm ordering. It is a different type of mammogram and or ultrasound and or other imaging that's done. And then lastly, I think Dr. Maxey asked about postmenopausal hormones.
Hormone therapy.
Hormone therapy, again, very important. There is so much available now, right? I have people ordering things offline. They're taking maca root. They're getting pellets. You can go to Whole Foods. And so the one thing, again, if we walk away today, the one thing I wanted to convey to the audience today is if you're taking hormones, estrogen containing drugs or medicines, even if they're quote unquote natural, many people think because it's natural, it's not dangerous or harmful. Anything with the estrogen, natural, made in a laboratory, chemical, mass produced, it doesn't matter. You turn on that receptor, the same things can happen. So I've had people coming in almost self-induced endometrial cancer, bleeding, because they're taking natural hormones that they did not realize has the same effects as a prescribed pharmaceutical method. And so it's important, if you have a uterus, right? If you have a uterus, you have to take an estrogen and a progesterone to prevent uterine issues and uterine cancer. If you've had your uterus removed, those women may take only estrogen containing products. But if nothing else, we walk away that you should be in conjunction with your doctor. You should be reporting to all of your doctors, even when you're taking hormones you've bought and ordered offline or bought at the natural store. You should even report the pellets. Sometimes I even have people forget to tell me they have pellets in, right? I just had a lady who had a prior stroke who went and got pellets because she said everybody else at work had the pellets and they look great, Dr. Lawson. So I went to get them too. Well, that's a contraindication for someone who's had a prior stroke. So we have to ask enough questions.
Can you go back over that again? Having a uterus, I want to hear more about this. You say that if you're postmenopausal and you're having what I call power surges. What is
power surges? Okay, I like that.
Well, we call it hot flashes, but what is the recommended treatment for those? You say
right. If you have a uterus and you want hormones, those women would take combination hormones, an estrogen and a protective progesterone. Because if she takes estrogen unopposed, she could induce not only bleeding, but at worst case scenarios, precancer or uterine cancer. If you have an absent uterus, the hormone therapy those women typically would use would be estrogen alone. There would not be the necessity to take progesterone.
And I've got one last point before we go to our final comments. In a postmenopausal woman who has stopped her periods, and she's now 70, 75 years old, and she has another period, what are you comment about that?
Rush her to the OBGYN. Rush her to the OBGYN right away. That is abnormal.
Okay.
Amen.
Well, thank you so much, Dr. Lawson. We so enjoyed your information, and I hope that in your busy schedule, you'll consider coming back with us. Would you care to have final comments?
Oh, well, thank you. Just thank you for having me. Thank you for the opportunity to educate. I love educating my community. That's what is most meaningful to me. As a physician, I was just in a room and a physician said he did not think doctors had a role in education. And I looked at him because I think we have the primary role. And so thank you for having me. Thank you for the opportunity. And it's so great to be with you all today.
Thank you so much. Dr. Hines?
Thank you again, Dr. Lawson, for just a wonderful discussion. And as you said, you demonstrated your superpower in keeping it real. I think that one of the many things that we should all take home from this is we talked about a lot of topics, right, where there's nuance there. And so none of these little kind of tidbits that whether it's aspirin or blood pressure cuffs or cervical, like all of these things, we need to be talking to our primary, whether you should be in birthing centers. Your individual circumstance is not going to be decided in this discussion. But what I think the discussion did do for everybody is give you, when you go have the discussion, it gives you a place to say, well, why? Right. And well, why do you think I should stop? Right. Or what are the other things I should be talking about with my provider so that then they can give me the best response that's for me, not the one that was from my neighbor or my friend across the street. So thank you so much for the inclusive and comprehensive way that we talked about some of these really broad topics.
Excellent. Thank you all.
Dr. Walsh?
Echoing everything that Dr. Hines said, Dr. Lawson, thanks again for spending this time with us. Two quick points. One is that Dr. Lisa Kervin-Dawes, who is in Jamaica and joins us regularly, put a comment in the chat about people afraid of being perceived as weak. And you covered this earlier. And I just wanted to make that statement that this isn't just an urban issue. It isn't an American issue. It is such a broad issue of folks who are concerned about. I always tell people the only reward you get for doing everything by yourself is loneliness. And so I try to encourage folks to, one, lean in, as you said, but also to reach out if there is help that they need. So I want to just say how much this is appreciated. And my final comment is this. You talked about that annual exam that women would expect, even if they don't need a pap exam. And I like the way that you went through. This is what your doctor should be doing, because so many times we will go to the doctor and we don't know what the doctor should be doing. You walk in and 3 seconds later you walk out and the doctor, not any of the doctors we know, but the doctor is billing for an annual exam and you didn't get all of the things that you just said. So I love the way that that was listed. And I think it's important for us to know that there is this thing called the standard of care, and doctors like you and other folks are willing to talk about what that is, so that when someone goes in to see their doctor, I know we're all busy. We've got way more patients than it anyway. That covering what you should expect. We as patients have expectations that should be clear, and I'm just appreciate you putting that out there. Thank you.
Thank you.
Dr. Barbara David Stevens.
So, Dr. Lawson, I want to thank you for sharing your very busy schedule with us. Our chat is blowing up with accolades, but more importantly, you have demonstrated and given a concrete example of what Black Health Trust is trying to do. We are trying to get the information that people need in order to get the health benefit outcomes that they deserve when they go to their providers. If you don't know what you don't know, then you never know. And what we're trying to do is close that gap or eliminate that gap. And you did a marvelous job today in a very short period of time on what you really need to know, the nuts and bolts of what you need to know as a woman, when you are either dealing with pregnancy or your overall health. This can never be said too often, which is my way of saying, I hope you are willing and able to come back again, give us a refresher, give us new nuances, give us new developments, whatever is on your heart and mind at that time. But please remember us.
Thank you. I will. Thank you. Thank you all for having me.
Again, thank you so much for coming and doing such an excellent job of communicating to us. Everybody have a great rest of the Sunday. Simon, thank you for putting the flyers together. And thanks everybody for joining us today. Have a great day.
Thank you. Bye-bye.
Good day, everyone.
Thank you.